Welcome to Conspiracies Against Wellness with your host, Janelle Elgaway.
Good evening and welcome to Conspiracies Against Wellness. I'm your host, Janelle Elgaway. We will take a few questions at the end, about the last 15-20 minutes of the show, which is around 8:40, 8:45 p.m. So if you have any questions for tonight's guest, please call in at 415-915-2291. Tonight's guest is Dr. Michael Schatman, a clinical psychologist who has spent the last 30 years working in multidisciplinary chronic pain management. Welcome to Con Nation, Dr. Schatman. How are you this evening?
Hi. For whatever reason, you're not coming in clearly.
Okay.
Can you hear me?
Yes, we could hear you.
Okay, now I can hear you, but it was broken up. Okay.
Okay. So, would you mind telling us a little bit about I know you have a quite extensive background. Can you please share a little bit about who you are and your professional background?
Yes, I'm a clinical psychologist who has spent the last 32 years working exclusively in the area of chronic pain management, and I spent 16 years developing and running an interdisciplinary pain program. I spent time in private practice until this past summer. I'm also a researcher and head up a research team in Boston now at Boston Pain Care, and I'm a teaching faculty in the Department of Public Health and Community Medicine at Tufts Medical School, also in Boston. And finally, I'm the editor-in-chief of the Journal of Pain Research.
Wow. Okay. Well, so tonight we're going to focus on medical health insurance within the United States. In order to do that, can you go into what has caused the opioid crisis and what's perpetuating it?
Well, one of the things that I struggle with is that so many people say, well, this is the cause. For example, the pharmaceutical industry's fraudulent marketing for many years ago is the cause. Or, pill mill doctors, or, addicted patients. And there's not a cause. There's about 12 different causes. And I think the one that gets really lost, or two that get really lost, are the for-profit insurance industry in this country and the hospital industry.
Okay. How was the for-profit industry created? And well, for modern health insurance today, that we understand it of it today, how was that created?
Well, actually, I'd written a textbook chapter about that a number of years ago, and insurance is just a risk-sharing scheme. And, if you have insurance and you need a spinal fusion, some other type of expensive surgery, it can be a lifesaver. And some people pay insurance premiums and they don't use their health insurance whatsoever. But some not so ethical but very, I guess, intelligent people figured out that if they added on additional fees, so the premiums are more than they pay out, then they became moneymakers. They became for profit. So there's a couple of different angles. One is cost containment. And this is the one that is really hurting people with chronic pain in the United States. Because I'm sure everyone who's listening tonight has had services that they've been referred to that have been denied. And the insurance industry, their way of dealing with things is delay, deny, and defend. 3 Ds. Mm-hmm. And right now, the insurance industry is incredible. incredibly profitable. For example, 2016, Aetna's revenues, they were over $63 billion.
Wow.
And, there are insurance CEOs who are making in salaries and bonuses over $60 million a year. And it was frustrating to me for many years as a clinician because I could not get my patient that 11th or 12th session of physical therapy, yet their CEO would bring home over $61 million.
Wow. What is the purpose of this delay? Like, why do they do that?
Every day that money is sitting in the insurance industry's pockets, it's invested, it's making more money.
Okay.
It's very simple. And it sounds like, well, what's a few weeks? Well, a few weeks could be a lot of money when we're looking at millions and millions of enrollees.
Is it like almost like they gain a tax on it? Like, I mean, if it's in the bank longer, they'll make more money off of it? Is that what you mean?
Right. The longer they hold on to the money,
Mm-hmm.
the more money they're going to be making off of your money.
Have they always done this? Have they always delayed treatment?
Well, when I started back in the 1980s, it was not as problematic as it is now.
Mm-hmm.
And now it's become the norm. And as a result, insurance companies have become, more and more profitable. And, of course, the quality of care has deteriorated even further.
What tactics have you seen by these providers when they've denied or delayed treatments over the years?
Well, they talk about, we have to send this to the board that has to look at this. We have to send this to our in-house medical directors. And they come up with a lot of different excuses. And, again, they often come back with an answer of, no, we're not going to cover that. And I find this extremely frustrating because, as a journal editor, and a researcher, I'm very interested in the evidence basis. And we have some evidence-based treatments that used to be available that have essentially disappeared. And these evidence-based treatments were very cost-effective, yet expensive. The problem is that the insurers know that the average American is going to change insurance companies every 3 years.
Mm-hmm.
And what happened as a result? As all of the safe and effective chronic pain management programs closed down, interestingly, that's just about when the opioid crisis started, because physicians did not have an option other than to prescribe their patients opioids.
Do you think that's coincidental, or do you think that was done on purpose?
I think it was done on purpose not to create an opioid crisis. I don't think anyone really wanted to create an opioid crisis, but rather insurers decided that they didn't want to pay for interdisciplinary pain management programs, such as the one that I developed and ran in Pennsylvania for 16 years. And, in 1999, we had over 1,000 of these programs in the United States. Now, outside the VA and the military, we're down to 68.
Can you talk about what was offered in these programs a little bit in detail?
Yeah, they all differed, but they had the same core. The program I ran was a 6-week, 35-hour-a-week program that involved medical management, psychological counseling, physical therapy, occupational therapy, biofeedback, vocational counseling, nutrition, aquatics therapy, and basically these programs are referred to as functional restoration programs. And we were essentially teaching patients how to treat themselves and manage their pain. And interestingly, they were dramatically effective in terms of not just getting people, feeling better and back to work and back to activity, but also reducing reliance upon opioid analgesics.
Mm-hmm. And back then, they didn't prescribe opioids like this, correct? So was this the way they cared back then?
Was this
was that their preferred way of caring for pain management or any chronic issue?
Of course, it has been demonstrated in study after study and systematic review after systematic review to be the most effective and safest treatment. Unless someone falls off of the treadmill, I mean, no one's overdosing of wellness. And, these programs were wellness programs, and they were very effective. And again, all over the world, countries that don't have insurance but have the sense to have national health systems, they are growing these programs, the number of programs. And I published an article, International Perspectives on Interdisciplinary Pain Management, at the end of 2012, and we looked at the trajectory of the number of programs in the United States, which has gone plummeting, while all the European Union nations' programs had increased dramatically.
Mm. And because I know you get to see other countries and their programs, their health is probably a lot better than ours is, correct? I mean, are they?
Their overall health is much better. The World Health Organization, in its most recent ranking, rated the United States number 37.
Wow.
37, despite the fact that we spend more than twice as much per capita as any other country out there.
So, why aren't we doing this in the United States? Is it all about money?
Well, I think that it's all about the money. I think the big problem is that in the United States, we have discovered that it's a lot more profitable to treat illness than it is to prevent it.
Mm-hmm.
So, we have trouble filling residency positions in, primary care, which is, generally preventive medicine, ideally. And everyone wants to go into the big paying, cosmetic plastic surgery and neurosurgery and, a lot of specialties where we have too many physicians.
Okay.
But it's all about the money. And I refer to this as the United States of money, and I really believe that while it hurts all patients, it hurts patients with chronic pain in more different ways.
Mm-hmm. I wanted to backtrack a little bit and talk a little bit, kind of go into depth about, the health insurance that's going on in the United States right now. What is managed care, and does this help or hurt patients, in your opinion?
I think managed care is an abomination. We used to look at all different policies, and they'd either be like an HMO, a health maintenance organization, which we manage care, or a PPO, preferred provider organization, where you have your choices. But even a PPO is a type of managed care because the physician and the patient are no longer making the decisions about care. These decisions are being made by whom? By insurers.
Have they always done that?
I'm sorry?
Have they always done that? Have the insurers always decided on the type of care, or no?
Minimally. For example, different drugs. The more expensive your policy is, the better types of drugs that you can get for any types of medication. Any medication you need, you can be more likely to have it covered. But now, again, none of the insurers, whether they're managed care or even the very expensive preferred provider organizations, none of them are wanting to take care of enrollees because their focus is cost containment and profitability. And this even goes down to, state level workers' compensation. In the state of Washington, an associate medical director, when I was trying to get services for a patient who was very badly injured and they were being refused, I said, you have to pay for it. You have an obligation. He said, I have no fiduciary obligation to the enrollee, only to the taxpayers of the state. So the enrollee, i.e. the patient, is being written out of the equation progressively more. And this is why pain care is so awful at this point, or a big part of it.
Right. So if an insurance company refuses to pay for, a treatment or surgery, what course of action, or if any, does a patient have in order to obtain proper care for their pain management? What should they do at that point?
Well, this is going to be a very discouraging answer, but unless you have one of the rare doctors who is willing to be a radical advocate, which is something I did, in my 30 years in the trenches with patients, there's not that much that can be done. And unfortunately, physicians don't want to spend the time advocating for their patients because they don't get reimbursed for doing such, and it's very time-consuming. And it's also frustrating because, I've written letters and explained the evidence basis of a treatment and the rationale in a way that would be worthy of, being published in a peer-reviewed journal. But I think we've all seen the 60-minute segments on these doctors who do these reviews, who do nothing else and make hundreds and hundreds of thousands of dollars by, and their only job is to just say no.
Right. Yeah, I saw something on that about the insurance companies too. How they'll deny and deny and deny it over and over again. I don't know, I guess hoping for it to go away, or maybe the person will just not even be there anymore. I'm not sure why they would do that.
Right.
Yeah. So if a doctor does order, a treatment and the insurance company denies it, who's responsible at that point? I mean,
who's responsible?
Mm-hmm.
Well, if the doctor orders it and and the insurance company refuses it, again, the doctor, and even if the doctor appeals the decision, the doctor cannot take a gun and go to the insurer and say, you have to pay.
Right. Is that illegal?
There was, is it what?
Is it illegal for insurance companies to be able
to...
No,
unfortunately, it's not illegal. It's capitalism gone awry.
Wow.
Okay? There's a little bit of bait and switch, but this is very, very hard to prove in court. And, people who've been injured by insurance companies have tried to sue them with very little luck.
Mm-hmm. So if people... Go ahead, I'm sorry.
No, please go ahead.
I was just... I wanted to talk about premiums and deductibles. People that pay high premiums and deductibles, and have you noticed if they're still denied care by their insurance? And if they're paying for that, why wouldn't they be able to get those things? I don't understand that.
I'm sorry, Jill, but you're breaking up.
Okay. I was just talking about, so if people pay like a high premium or a deductible and they're still denied by their health insurance, what can they do about this? Because the thing is like, if you're paying for it, I don't understand why you wouldn't be able to get the care that you need.
Well, if they're denied, again, there's pretty much nothing that they can do about it. People say, oh, call the state insurance commission. But the state insurance commission, their hands are tied. And, it's not like you can just switch insurers. Most people get their health insurance through work. And none of these companies is any better than any of the others. Mm-hmm. Certain companies do get a lot more complaints. And there's some of the real big ones, the ones, bringing in, tens of billions of dollars in profit every year. But, again, these are publicly traded companies, and they're trying to make profits for the shareholders. And the shareholder is the person to whom they feel they have an obligation, not to the patient or the enrollee.
Can you talk a little bit about what the impact of pre-authorization is concerning medications and treatments? Is it
there are a number of different implications. I mean, very simply put, if a person is in a lot of pain and a doctor says, I want you to have this medication, but then they have to wait several days for pre-authorization, because it's a medication that requires it based on that insurance company's formulary, and that's going to be several more days during which that patient is going to suffer. Mm-hmm. And, a very good example of that, I think, would be, abuse deterrent formulations of opioids. And, we have, or not we, but the pharmaceutical industry has made safe opioids. But insurance companies don't put them on their formularies because they are more expensive, because they're patented drugs and their patents are still active. These are relatively new drugs.
How did
and they
go ahead.
So not only will they require pre-authorization, which can take time, but then after several days of waiting, patients are often told, no, we're not going to pay for this.
Wow.
Then they have to go back to their physician and get a generic medication. And the problem when we're talking about an opioid, generic opioids don't have any abuse deterrent qualities, and these are the ones, when they're in the wrong hands, can be so easily abused.
When did you start noticing that there was a shift from the different programs where you could get pre-care or to teach patients how to get care? When did you see from that switch to the opioids?
I'm sorry, you broke up.
Oh, when did you? When did you see that it was switching over to opioids for pain management or care management on different things? When did you notice
around 2005 was when I noticed it, because it was right around 2000 that insurance companies started closing down the interdisciplinary programs. They did that by saying, we don't pay for that. And I published a book on multidisciplinary pain management in 2007 that had chapters written by a lot of the top minds in the country. And I wrote about the issue of insurance companies trying to make interdisciplinary pain care go away. And they've been wonderfully successful in doing so. Mm-hmm. So what does the physician do? The physician orders, the next best thing, which oftentimes are opioids. And opioids are really good medications, but they're not great long-term medication. But if it's nothing or opioids, then opioids are important. And, with this whole opioid crisis thing, which, was a prescription opioid crisis due to, again, as I said earlier, a number of factors, the insurance industry was not particularly concerned. And lo and behold, now the insurance company is saying, oh, we're not going to be paying for, X number of opioids. We're going to start paying, for only so many, milligrams, so many morphine equivalents of an opioid. And, they say, it's a socially responsible thing that we're doing. And it has nothing to do with social responsibility whatsoever. It's all about their wanting not to have to pay for drug rehab, because a certain small percentage of people on high-dose chronic opioids will develop problems and will need rehab. Right. So, again, they paint themselves as altruistic, and they do not care about you as a patient in the least.
Do you see them putting a tax on opioids at some point?
Well, actually, right now, Bob Tillman, Dr. Bob Tillman, and I, and the attorney, Katie Dunsing, are writing an article on, I believe it's 8 states that are trying to get an opioid tax across. And, there have been things in different states, per pill, per milligram, per unit. And this is the most ethically horrifying thing I've ever seen in my life. And if this goes through, it's going to kill countless thousands of patients. Because a lot of people with chronic pain are on disability. Mm-hmm. They can barely make ends meet. And if they have a, quote-unquote sin tax imposed on them for their pain medication, very, very few people with chronic pain abuse their pain medication. Mm-hmm. Looking at the research, we believe it's about 0.5%. You don't see diabetics having to pay a tax on their insulin. You don't see people with coronary artery disease, cardiovascular disease, having to pay a tax on their beta blockers. Why opioids?
Well, why opioids?
The most pathetic thing in the world. And my concern is that the result, should any of these taxes go through, there will be a number of patients who, A, will consider suicide as an option because they just can't afford their medication, or B, go out onto the street and buy illicit fentanyl and its analogs, which are marketed as, oxycodone or hydrocodone, but are much, much stronger, very inexpensive, and incredibly deadly. Mm-hmm. And my hope is that we can get this article out in print and, tweet it to every legislator out there. This would be a dramatic mistake. My understanding is that the whole notion came about because people from Physicians for Responsible Opioid Prescribing, or PROP, the anti-opioid zealots, were interested in seeing more treatment facilities, drug treatment facilities open up. Mm-hmm. And they had recommended that states consider taxing and using the revenue to build treatment centers.
Well, let me ask you this, though. Why tax opioids for addiction centers? I mean, the people.
Why?
Why would they tax opioids to help fund the addiction centers? Are they basically saying that the addiction centers are there because of the opioids? Like,
they are saying that the problem with addiction in our society, mm-hmm. Is due to prescription opioids. Dr. Ziegler and I wrote an article in the Journal of Pain Research in October using state data showing that only 15% of the so-called prescription opioid overdoses in this country are actual prescription opioid overdoses. Mm-hmm. Through the New Hampshire Department of Justice data, we were able to demonstrate that 85% of these deaths were actually due to heroin and illicit fentanyl products, generally from China. So, to blame the skyrocketing death toll on opioids, on prescription opioids, is ridiculous. And the CDC, the Center for Disease Control, they've been talking about 17,000 prescription opioid deaths a year, when we estimate that it's closer to 2,400. Mm-hmm. And a few days ago, in response to our article, the CDC wrote an article discussing how they're going to start reconsidering the way that they count prescription opioid deaths. There's so much disingenuous stuff going on out there, and everyone wants to blame the doctor who treats patients with chronic pain, the patient themselves, and I think our wonderful president, was talking about a 30% reduction across the board in prescription opioids.
Right. And is that on top of the already reduction that they've done in the last few years?
Correct. Now,
wow.
Now, we've seen a decrease in prescription every year since 2009. So we are down to the lowest level of opioid prescribing in years and years and years and years. Going back into the into the early years of this millennium. But in all his brilliant wisdom, our president wants to see it cut back 30% because he seems to think that will solve the opioid crisis. Mm-hmm. Even though 85% of it is illegal drugs, heroin, carfentanil, etc. So, we are a mess here.
Yeah. We have a question on YouTube. Pamela Olson asks, fentanyl is showing up in illicit drugs, which is spawning this bill from the federal government. So why isn't the FDA or the DEA fining and closing down those pharma producers of fentanyl?
Well, the fentanyl is, fentanyl, okay, it's important to understand when we hear fentanyl, we think of a prescription drug. Fentanyl has many uses pharmaceutically. It's rarely prescribed other than for cancer pain and for operative pain, okay? Mm-hmm. But this is not what is killing people. This is not, the drugs that are killing people are not FDA approved.
Right.
Fentanyl can be used safely. I've had surgical procedures where they give me a little bit of fentanyl and put me in a twilight kind of state, and guess what? The next day I was not out on the street trying to get fentanyl.
Right.
But people hear that word fentanyl, and I ask them, I say either prescription fentanyl or illicit fentanyl. Mm-hmm. Because prescription fentanyl is killing no one and is rarely prescribed. Illicit fentanyl may kill 40,000 Americans, 50,000 Americans this year.
What do you think about the current policies for like Medicare, Medicaid, and the VA? I know they're all different. Can you talk about those a little bit? And are they doing?
Well, I'm happy to talk about them. I did my residency to a VA hospital where pain care was very good in Virginia. Some of the best pain programs in the country are at about 8 or so VA hospitals around the United States.
Wow.
And unfortunately, there's different levels of VA. So is it, it's like the Wizard of Oz. Are you a good witch or a bad witch? Are you a good VA or a bad VA? And the VA system has its flagship, hospitals. One of them where they treat pain perhaps better than anywhere in this country, and that's the Haley VA in Tampa, Florida. And they get a lot of resources and a lot of funding. And if you're lucky enough to go through their interdisciplinary program, you're getting great care. As good, if not better, than anything else in the country.
Wow.
But so many of the VA hospitals are backwoods and treat very rural, underserved populations, oftentimes very uneducated populations. And for years and years, the doctors had nothing to do other than throw opioids at these patients. And now they're doing just what we're seeing in the private sector, and that is, involuntarily tapering people off of opioids just because that's their policy. Mm-hmm. They're doing it without a good evidence basis, but this is what they're doing.
I heard is this true? I heard the VA does not any longer prescribe opioids. Is that true?
No. It number one, it depends on the VA. Mm-hmm. They're moving toward a prescribing of opioids for chronic pain, very controlled dosages. But again, it varies depending on the specific VA hospital. But none of them are loose with opioids, certainly, and they continue to become harsher and harsher. And because they're underfunded, thank you again, Mr. Trump, they feel that they have, they don't have the money to bring in other effective therapy. So you have an at-risk group in veterans, and a lot of the pain patient suicides that we're seeing are among veterans. So the VA, a few years ago, it looked like they were getting their act together in regard to chronic pain, and now, because I say of underfunding and some maybe some faulty policy, they're not anywhere near the top of the heap.
Right.
Now, moving on to the second part of this, you'd ask about Medicare and Medicaid. There's a bill, I'm not sure what it would be called, but the Center for Medicare and Medicaid Services is planning at the end of this year, the beginning of 2019, to put a hard cap of 90 milligrams morphine equivalent on opioids.
Mm-hmm.
And for a lot of patients, that's going to be fine. But what about the ones who need more? What about the ones who have intractable pain that's so severe and multiple pain generators? What's going to happen to them?
Right.
Where I work at Boston Pain Care, though I'm not clinical at this point, I work with our medical director, and we're looking at how we're going to taper some of our Medicare patients who are above 90 milligrams daily. Because if we don't, we will potentially be fined, and these fines for breaking CMS policy are very hefty, and also potentially lose our right and our ability to treat people with Medicare. Now, there's a brief public comment, and, people and pain societies were able to make comments, and one society with which I'm involved was very vocal in its comments, but no one at CMS is going to pay attention to it. They want to do this.
Right.
And this is what's going to happen. So I'm telling patients who have chronic pain, who have Medicaid and Medicare, who are at high dosages, to go to their doctors now, not a week or so before the end of the year, and start a gradual partial taper.
If you are willing to pay out of pocket for your prescriptions, would you be able to do that? Because I know some of these medications, especially the older ones, the generic, they're not that expensive out of pocket.
That's a very good and very challenging question, Janelle, because if you are on Medicare, you cannot go to your doctor and say that, hey, what if I pay out of pocket? Because what does that look like? The other piece of that is if you're a Medicare participating physician, you cannot charge, a patient who has Medicare privately. That's against the law. Now, a person can go outside to a non-Medicare participating provider, but even they are becoming very frightened. The cash practices, they're becoming very frightened, because if you pay me cash and I give you an opioid, what does that look like?
Right.
So it's a very tricky, very disturbing situation, and I hope that providers out there are going to their patients saying, hey, let's start this early rather than at the last minute. So
at first you have to get a doctor to be able to be willing to take cash, right? So that's the first part of it. But then the second part, because what if I had diabetes, and I was on Medicare, and I went to a doctor and didn't use my Medicare, and I said, hey, can I pay for my office visit with
Janelle,
yes.
Again, you're breaking up.
Sorry about that. What if I paid, out of pocket, and I was I had diabetes, and then I got a prescription for, insulin, and I wanted to go to my pharmacy and pay out of pocket for that. What's the difference between
Well,
opioids
again,
and that?
no one cares about insulin.
Right.
We don't have an insulin crisis. You know, the public, because of the media, heavily because of the media, has drank the Kool-Aid and believes that people with chronic pain and opioids are addicts.
Mm-hmm.
And that's just not true. Again, the addiction rate has been found to be around 0.56%.
And that hasn't gone up or down,
Roughly one.
right?
I'm sorry?
It's not like there's been more addicts suddenly, correct? I mean, it stayed at the same level.
Well, again, there's not any more prescription opioid addicts or people with opioid use disorders, but because the illicit fentanyl products, to which I alluded earlier, are so incredibly cheap, we now have, countless hundreds of thousands, if not millions, of these people.
Right.
Heroin has been around for a long time, and there have been people who have had, heroin use disorders. Now, even the heroin is laced with fentanyl. If you remember, I'm not sure if they still sell it, there was something called Hamburger Helper.
Mm-hmm.
And you'd add your hamburger to it, and it would help it go further, typically used in low-income families. Well, that's what fentanyl is, because fentanyl, the illicit fentanyl, is incredibly cheap, incredibly plentiful, and it's now what you're finding in heroin. And it's a lot stronger than heroin. And this is a big part of why our death toll is climbing.
We're starting to get some calls. Would you mind if we took a few of them? And I just wanted to just tell the audience quickly, too. Again, our phone number, if you want to call in for with questions, it's 415-915-2291. Caller from area code 818. What's your name and where are you from? Hello, caller from area code 818. What's your name and where are you from? Hello? Brian, are they on?
They're on.
Okay. They're not answering.
Hello?
Hello? Hi. What's your name and where are you from?
Hello?
Yeah, I can hear you now.
Okay. No, we're taking a call. Caller from area code 818. What's your name and where are you from? I could hear them. I don't know if they know that they're on. Okay. Well, we'll just keep going. But yeah, if anybody wants to call in, please go ahead. The lines are open now. And I didn't mean to interrupt you at all. I just wanted to remind everybody that they can take calls in. So I guess I would like to know, where do you see this going? Where do you see, well, first of all, I guess, health insurance and healthcare going within the next few years? Dr. Schatman? Hello? Are you still there? Is he still there, Brian? Okay. Well, when Dr. Schatman comes on in, we'll just start talking again. I'm not sure if he got dropped. Did he get dropped or is he calling in? No? Okay. Well, we can't hear you, Dr. Schatman. This is just such a difficult subject, and I just wanted to say I could see everybody on YouTube talking about all this, and I appreciate all your comments. This is something that we need
Hello?
to... Hi, Dr. Schatman? Hello? Dr. Schatman? I just apologize, everyone. I don't know what's going on. Let me just text him quickly. Okay. So if anybody wants to call in, though, with a question or comment, please go ahead. That would be awesome. I was thinking about federally with especially, I think what it was, I think it was $6 billion that they're going to put towards the whole community for addiction. I was wondering if that's where our taxes would be going to.
Hello, you reached Dr. Michael Schatman.
Oh.
I'm unavailable to answer your call
Hang on
at
one
this
second
time.
here. Hey, Brian, he's going to call in, he said. Hang on. Oh. Hello, Dr. Schatman?
Yes.
Hi there. Not sure what happened.
Look,
Okay, I can hear you now. Can you hear me?
I can hear you. You're not breaking up.
Okay, great. I think we just had a bad line. And we did have somebody call in, but we couldn't get them through either, so I'm not really sure. I wanted to ask you, a few people are talking about pill mills. Do you still really see pill mills around anymore?
I'm sorry, Janelle, you're breaking up again.
Okay. It might be your phone, is it? It's not us. I could hear you. Can you hear us? Hello?
Now I can hear you.
Okay, great. Okay.
Yes.
So, we have another caller. We have a caller from area code 818. What's your name and where are you from, caller?
This is Scott Reed from California.
Hi there. What's your question for Dr. Schatman?
The question I had is, I've heard and read a lot about ketamine therapy, and I'm also looking into transcutaneous magnetic stimulation because my psychiatrist says the depression isn't really treatable with medications. I wondered if you had comments on that or had experience with it that you could share with the group. I think in regard to ketamine is kind of the new big thing, but the safety of ketamine, it's questionable, although the low dose use of ketamine is something that is seemingly effective and safe. I know there's a nasal ketamine at this point, and I've had patients on that who have reduced their opioid dependence, meaning that they still use opioids but at lower dosages. The problem with ketamine is that it can be hallucinogenic, and particularly at higher doses. So, if you are going to be receiving ketamine or interested, I think it's important that you see a physician who is expert in ketamine. Other piece of this, as we were talking about insurance, is that most insurances are not paying for ketamine infusion.
Does ketamine reset tolerance, do you know, to opioids?
No one's really sure. I mean, I think that's, at this point, urban myth. It's certainly not been empirically established. And there's a lot of theories on how ketamine works, but again, they're only theories at this point.
And so they aren't, a lot of health insurance companies will not cover it right now?
No. Particularly, in infusion form, because infusion centers get paid, are very, very expensive. And you may, I know one back in Seattle has like 2 half-day infusions or 3 half-day infusions for a week, and then, or for 3 days a week, I'm sorry, and then the next week 2 days, and the next week 1 day, and, that could be a $10,000 bill. And again, insurance wants to pay for nothing. They are doing clinical trials on ketamine, and if you can find one of those, going to, I think it's trials.org or trials.gov, one of those two, and get in, you could get some free ketamine treatment if you are put into the treatment group, but you could also be put into the placebo group, so you never know what you're going to be getting.
Actually, I've had ketamine infusions a few times, the day ones I have CRPS, RSD, and my insurance actually covers it, which is Medicare. So I've only known from me, but I've heard that from other places in the country. Is it a state-by-state thing? Is that why not everyone can be?
Again, you're broken up, and I can't hear what you're saying. You said that you received ketamine, and you got it through Medicare.
Yes.
And it was paid for.
Correct.
But that's not happening everywhere, and it's not happening with private insurances.
So is that?
And accordingly, private infusion centers that are cash only have opened up, and they're extremely expensive. The other thing is that an infusion center may be doing infusions of chemotherapy or
intravenous immunoglobulin. They do a lot of different infusions. And the ketamine is not that expensive a drug. And the hospitals are not making the money off of ketamine infusions. So they have a long waiting list, which pushes people who can pay into the private centers.
What do you think?
But again, there is no evidence basis for long-term use of ketamine, and the safety profile long-term has not been established.
What do you think about stem cells and the use of that?
Stem cells are very exciting, but again, this is the biggest enemy of the insurance company. Any kind of regenerative therapy, whether it be protein-rich plasma, injections, or stem cells. There's not insurance out there that will pay for that I'm aware of. They call it experimental. And even though, I was looking today online and just, I put in the word cervical and stem cells, and I got 1,600 hits in PubMed.
Wow.
So a lot of research is being done, but, they don't want to pay for it. And, this is the plight of the patient with pain, in that there's so much desperation that they will, if they can, try to pay for it themselves. But I know that, a physician with whom I worked in Seattle until relatively recently, they do, forced stem cell injections, and it was somewhere in the $10,000 range.
Wow.
You have to harvest the stem cells, and, it's an expensive process. I think it is the future of medicine.
Right.
Regenerative therapies of all types. And I think it will help chronic pain in a lot of ways. In animal models, it helps with spinal cord injury, and nothing helps with spinal cord injury. So it's very exciting, but unfortunately, I think we have to keep the focus on what are we going to do for patients who are hurting right now.
Right. And why didn't, it seems like they didn't even think about that, especially with them, wanting to, take everybody off of opioids. Like, what is the other part of care that they're supposed to take up if they can't have that? Is there anything?
Exactly. And that's the problem. A lot of the key opinion leaders in pain medicine in this country, with whom I work and lecture and write, they were not particularly pro-opioid. And it's interesting to see them turning around. And now there is the movement of, okay, you've taken away patients' opioids. Now what?
Right.
So whether it's insurance, regulatory agencies, it doesn't matter. Take the opioids away at this point, and you think, well, we're going to substitute this for this, but there is no substitute at this point, and that's why these anti-opioid policies, including those now being pushed by the insurance industry, are so egregious and so damaging to many people.
Yeah. What if this was, the perfect world, what would you want to see happen coming up for health insurance and the way patients are treated? What would that look like?
That would look like a completely government-controlled national healthcare system, starting in the beginning, meaning training more physicians. For years and years and years, the American Medical Association kept the number of medical school slots down in order to maintain a monopoly. And while, now things have loosened up a little bit, we're short 20,000 primary care docs in this country.
Wow.
And that's where most chronic pain is treated. We need to get into, what the Affordable Care Act referred to as pay for performance, because there are so many different procedures and surgeries that have no evidence basis for chronic pain whatsoever that continue to be done. I hear about patients getting palliative epidural steroid injections
Mm-hmm.
And if you look at the systematic reviews on epidural steroid injection, there's no evidence basis for chronic pain. For acute pain, yes. But when the inflammation and the damage is so chronic, there's no evidence for it. Yet curiously, the insurance industry continues to pay for needless surgeries, needless injections, other procedures that are not based on, the patient's well-being, but are simply driven by profit motive.
I've heard that those aren't FDA approved. Is that true?
I'm sorry?
The injections, the steroid injections, are those actually FDA approved? I heard they weren't.
Confident that they are.
Okay.
But again, to me, it's odd that the insurance industry is very happy paying for things that are expensive and are not evidence-based, and then they are rejecting things that are that are also expensive but are evidence-based.
Right.
And sometimes I think it's just arbitrary, but they have actuaries, and their actuaries are the real bean counters, and they figure out how the insurance company can make the most profit. And again, the well-being of the patient is not even in the equation at all.
Something that personally happened to me, and I would be interested in what you think about this. I had to get 5 neck surgeries overall. And after all of them, I was always I was curious as to why they couldn't do them all.
Breaking up. I'm losing you.
Can you hear me?
Yes.
Okay.
No, I can.
I was wondering why they never would do the surgeries all together. And when I researched a little bit more, I found out they don't make as much money if you get a surgery altogether. You had to get one and then another and then another. And,
right.
Yeah.
Right. And again, that's classic stuff. There are certainly reasons for not doing, replacing 2 hips at once.
Right.
But for certain surgeries, you can do them at once. But hospitals don't want to see that happen because, again, as I said, the hospital industry is almost as much to blame as the insurance industry. They're interested in profit, even if they're called not-for-profit hospitals.
Mm-hmm.
So it's all a great big scam at this point. And unfortunately, in scams, people suffer. And right now, the people suffering are those who suffer from the disease of chronic pain.
We have a question on YouTube. They want to know if you can talk or if you know anything about cutaneous magnetic stimulation. Do you know anything about that?
Are we talking about brain stimulation?
I'm not really sure. I've never heard of it before. Just cutaneous.
I know they're doing in certain places brain stimulation for refractory depression. I know a lot of the leading psychiatrists in the country are making a lot of noise now about antidepressant therapy that was never meant to be a permanent therapy, but a short-term therapy. But again, I've worked in pain, not in psychiatry, so I can't tell you much about it. I understand it's like just like spinal cord stimulation. There's big advancements in that, and on those that I do work with, and I see great improvement through technology. But the psychiatric piece of it I can't address. And again, I'd also question, if it is expensive because of the technology, is insurance willing to pay for it?
Mm-hmm. What do you think about prescriptions being prescribed off-label for other things? Like, for example, they're pushing Neurontin and Lyrica right now instead of having opioids. What do you think about that?
Well, I think that the evidence basis of opioids for neuropathic pain is almost non-existent. The only opioid that is FDA approved for neuropathic pain is tapentadol, which is half opioid, half centrally acting noradrenergic.
Mm-hmm.
But, opioids are not the answer to all chronic pain. And, for neuropathic pain, while these are definitely imperfect medications, the gabapentinoids, like, you mentioned pregabalin and gabapentin, they have a higher evidence basis. The problem with them, there was a couple problems with them. Number one, the side effects are brutal. So the American Academy of Neurology, came up with a therapeutic window of 1,800 to 3,600 milligrams a day of gabapentin for chronic neuropathic pain. But a study was done shortly afterwards, finding that the average dosage was 856 milligrams a day, or less than half of the minimum effective dosage.
Wow.
Because the cognitive side effects are so brutal. So, it's interesting to see the anti-opioid zealots push, gabapentin and pregabalin and say, oh, these are much safer than opioids. Well, what if it's mixed pain? It may help with the neuropathic component. And then, as I mentioned, the side effects and the ability of patients to tolerate these medications is very, very problematic.
Mm-hmm.
So, again, this is simple people giving simple answers to really complex problems.
I know there was a few articles recently that came out, especially like in JAMA and stuff, talking about Tylenol works just as well for chronic pain as opioids. What do you think about that?
Well, I think the Krebs et al. Study in JAMA had some real problems to it, methodologically, which I'm not going to go into in detail, but also ethically. If Dr. Krebs is associated with PROP, an anti-opioid group, and if she is an employee of the VA system, which she is, which has strong anti-opioid policies, then what we refer to as investigator bias needs to be acknowledged. And that was never acknowledged in the article. And we're actually addressing that in an editorial right now. So, again, is Tylenol a substitute for, for opioids? I've had surgery, and, I was very happy to have opioids for a few days after surgery. But now I hear about patients, having hip replacements and getting Tylenol.
Right.
And, Tylenol is got its problems as a chronic medication, particularly at high dosages because of hepatic toxicity. And it's nowhere near as analgesic as are opioids. But the anti-opioid zealots will kind of create data through bad research and say, see, we showed you. As an editor-in-chief of a pain journal, I look at that and I'm just nauseated because it is disingenuous and it's going to get surgeons who are afraid of prescribing that, oh, well, we can just give them Tylenol. And this is happening.
Yeah.
And now I hear a lot of patients talking about, I'm not going in for any kind of elective surgery because I don't want to be tortured for days without pain medication. So I think when we see this kind of questionable quality research, then there's some problems because it ends up as a clinical reality.
Yeah.
Because people are just not trained at really evaluating research thoroughly.
We have another caller from area code 713. What's your name and where are you from? Hi, caller from area code 713. What's your name and where are you from?
Hello?
Hi. Hi, what's your name?
Hello?
Hello.
Andrea?
Hi, Andrea. What's your question for Dr. Schatman?
Hi, Dr. Schatman. Thanks for having my call. I was curious, recently the CDC published, or some CDC officials published in a different journal, a statement that perhaps the mischaracterization of prescription drug overdoses in the 2016 opioid prescribing guidelines. Are you familiar with that?
Are you talking about the very recent article that suggested that CDC is going to reconsider its way of counting opioid mortality?
Yes, exactly. Yes, that's exactly right. I believe that it was written in the American Journal of Public Health by some of the CDC researchers,
Right.
acknowledging that, that perhaps the way of describing or depicting overdoses maybe was not as accurate as it should have been when they released the guidelines in 2016. What I was going to ask you is, how do you see that affecting, or do you see it affecting, the juggernaut of government policies that are sweeping our nation? Was that data unreliable, and should all of these individual states, medical boards, and at the federal level, should this legislative effort be stopped so we can develop policies based on better numbers, or is this an insignificant admission?
Well, I think it is significant, and I think that the article that I wrote in October of last year with Dr. Stephen Ziegler, the policy guy from Indiana, about the gross exaggeration of the CDC's opioid mortality, shamed CDC into writing this article and reconsidering the way that they're going to be counting opioid deaths. Now, my read of that article is that it's still unclear. And I can promise you that while, this year's death figures are going to go down, prescription opioid mortality figures are going to go down, they will not go down sufficiently. And once they're released, I suspect Dr. Ziegler and I will write another very scathing article. And, unfortunately, CDC, while they're supposed to be scientists who are protecting, Americans' well-being, they're incredibly non-scientific sometimes, and they choose to be agenda-driven rather than data-driven. So I think this may be a start, but I'd be very surprised if it brings the numbers down to where they really are.
Would it be information that you believe, like, say, advocates and people are affected could be bringing to their legislators to say, look, this whole thing was based on numbers that may not have been counted correctly? Like, please don't pass, like, for example, the Missouri proposed legislation that's going to sanction 8,000 physicians if they prescribe longer than 90 days. These policies are just going to be so destructive to both physicians and patients. Is this enough to go on to make a case that we shouldn't be building policy on this?
Well, again, I think that legislators are listening to the CDC and they're not listening to the real scientists. And,
right.
The article I wrote with Dr. Ziegler, Pain Management, Prescription Opioid Mortality, and the CDC is the devil in the data, which, has gotten a lot of reads. I believe it's gotten over 15,000 reads so far, which is a lot of reads, actually over 16,000 reads so far, which is a lot of reads for an academic journal. Generally, they get about 1,500 reads, and this one's gotten 10 times that. But until legislators start working with the true pain scientists in the country, people who are in the trenches or have been in the trenches recently with patients and understand the reality, they're going to keep on doing that, see no evil, speak no evil, hear no evil kind of thing, and just, drink the Kool-Aid. I don't think that legislators are unfortunately, I don't think that they're particularly concerned about the plight of the chronic pain patient. They see people with chronic pain as being a bunch of whiny addicts because that's what that's how the media has portrayed them.
Right, and our dealers are just in white coats. I think I was, somebody referenced the other day, we're just legal addicts, and our physicians are just white coat dealers, which is something that we're all trying to overcome. Well, thank you. I will reference that article. You said it was The Devil in the Details, published in?
Journal of Pain Research. It's called Pain Management, Prescription Opioid Mortality, and the CDC is The Devil in the Data. And that can the Journal of Pain Research, while it's high impact factor, it is an open access journal, so you can just go into it, put my name and Dr. Ziegler, Ziegler 2017. You'll find the article.
I believe it's on our website too, just so you know. So you could go on our website.
Wonderful. Okay.
All right.
Well, we've got some legislative meetings coming up in the next few days, so we'll plan to include that article and hope to make a difference. Thank you so much for your work and advocacy for common sense in clinical practice. We appreciate you very much.
Thank you,
You're
Andrew.
very welcome. Anything I can do to help.
Thank you.
Thanks. Well, we're going to have to wrap up here soon. I was just wondering if you wanted to have any last words before we get going this evening.
No, this is a lot of good questions, and unfortunately, I have to wrap up too.
Mm-hmm. Okay.
So I thank you for the opportunity, and hope to be back to discuss other issues in chronic pain management and the crisis that we're experiencing.
Yes, I would love that, and we will have to set that up sometime. So thank you so much, and thank you.
Okay.
Thank you, Con Nation, so much for the great questions and listening in tonight. I just wanted to remind everybody next Tuesday, Dr. Klein will be back with us for the Doctor's Corner, and next Wednesday, Dr. Ed Spencer will be here. I hope you have a great night and a good evening.
Listening to Conspiracies Against Wellness with your host, Janelle Elgaway. The opinions expressed on this program are those of the host and callers, and not necessarily those of EXG LLC, its employees, or sponsors. Copyright 2018 by EXG LLC. All rights reserved.